Hi, and welcome to the October 17, 2012 Plastic and Reconstructive Surgery Journal Club, held here at St Vincent's Hospital in Sydney. I'm Damien Marucci, a plastic and reconstructive surgeon. This is Dr. Owen Yang, who's one of the plastic surgery registrars. So, Owen, we did the usual 4 papers today. What was the first paper?
The first paper we did was on giant nevus sebaceous, and the title was Giant nevus sebaceous, Definition, Surgical Techniques and Rationale for Treatment.
Okay, so what do people think about this paper?
In general, people think it's a good paper. It's excellent for exam preparations. It goes through specific protocols for managing giant nevus sebaceous.
Yeah, so I mean, obviously it was a good paper in the sense that it combines both a review paper, almost like a meta-analysis of previous papers looking at giant nevus sebaceous, in particular focusing on the malignant transformation potential for these particular lesions, and then also the author reviewed his own data of the 6 patients which he had who had giant nevus sebaceous. One of the issues with giant nevus sebaceous is in the past people used to quote very high rates of malignant transformation as being a reason to operate on these children early. Then in the mid-90s they shifted the other way, saying, well look, there's actually only a very small risk of malignant transformation, so maybe you shouldn't operate. But these guys were sort of making the point that operating for cosmetic reasons, when you've adequately consented the patient, the family in terms of the small but not zero risk of malignant transformation, is probably a good way to go. They use a lot of tissue expansion and their results were very good. One of the only issues I had, they didn't say what was the optimal timing for insertion of tissue expansion, expanders for those patients who are going to be treated in that way. The other point they made is they thought that the upper limit for serial excision would be 3 episodes of serial excision, and if you thought you were going to need more than that, you really should go with tissue expansion. But people thought it was a good paper, didn't they?
Yeah, and also I think it's a good point to make that it's mainly for cosmetic purposes. These lesions they can transform and they can become more pigmented and more verruculous, and it's going to affect the patient's psychosocial mobility. Exactly.
Okay, then the next 2 papers were related. So the classic paper was the polycization of the index finger by Buck Gramco, and that's from the JBJS from 1971. And then the current paper going with that was Refinements in Polycization, a 30-year review by Upton, and Littler was a co-author there in the current PRS. So what do people think of these 2 polycization papers?
I think most people found that these 2 papers complement each other, and they give a good description, and also the newer paper, excellent diagram demonstrations of how the polycization is performed. Definitely in terms, it also gives you gives the trainees a good stepwise approach to polycization.
Yeah, and actually those drawings in the new paper are actually all done by Littler himself, which is just fantastic. They're beautiful diagrams which very accurately reflect the various steps of the procedure and illustrate the salient points most effectively. So yeah, I mean, I think it's pretty hard to argue with these 2 papers. Both of them had over 100 children who'd undergone polycization, and yeah, it was all pretty good. Okay, the last paper was the usability of the upper eyelid crease approach for correction of medial orbital wall blowout fractures. This is a Korean paper published in the current PRS, and what do people think about this paper?
People thought that it again gives a good approach to management of medial orbital wall fractures. In the audience, there actually wasn't a lot of people that had experience with this approach, but those that have say that it's an excellent approach. They were able to visualize the medial orbital wall appropriately, and also towards the posterior aspect of the medial wall, and able to give them enough room for plate insertion.
Yep. The other thing that Dr. Scott Turner was at the Journal Club, and he's had experience with this approach and thinks it's fantastic. One of the things which Scott was mentioning, is something I really agree on, is making a separate incision to approach the medial orbital wall, even when you're doing a combined fracture with the orbital floor. And if you've got a plate which you're trying to slide around from the orbital floor and up to the medial wall, you can insert it from underneath and then look at it from the medial orbital wall side and then make sure it's accurately placed. But yeah, this seemed to be a very good paper. One of the deficiencies of the paper which was mentioned was there weren't a lot of diagrams or intraoperative photos just exactly spelling out the technique, but their word description of the technique was pretty good and made it pretty clear. The other thing which they also highlight in the paper is that plastic surgeons were used to making upper eyelid incisions, and so this is a region of the body and where we're quite familiar with the surgical anatomy. Anything else to say about that?
No, I think you covered everything.
Okay, look, so that's it for today's Journal Club. For those of you who are there, I hope you got something out of it. And for those of you watching now, thank you for listening.